Thank you for joining us today for our webinar on food intolerance versus food allergy. What's the difference? I am Ranjit Dangel, Vice President of Engagement at Food Allergy Canada. Before we get started, I want to acknowledge that today, September 30th, is the National Day for Truth and Reconciliation. This day honors the children who never returned home and survivors of residential schools, as well as their families and communities. We acknowledge that North York is on the traditional land of the many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat, and the Seneca peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed with multiple Mississaugas and Chippewa bands. We honor Indigenous histories, cultures, worldviews in the spirit of reconciliation and acknowledge the current challenges Indigenous peoples continue to face today. Thank you all for taking a moment while we acknowledge this important day. I also want to note that our Back to School campaign ends today. Our campaign focused on building confidence and understanding food allergy and how to manage it. Today's session helps to build that confidence by providing clarity on the differences between food allergy and food intolerance. These two conditions often get confused because their symptoms can be similar. With this session, we'll hear more about these conditions and how you can distinguish between them. Before I introduce today's expert, I want to note just a few items. This session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions upon registration. There are some common questions that we'll tackle in today's session at the end. If you have additional questions during the session, please submit them in the question box throughout the webinar. We'll try to get to as many questions as we can. And lastly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. Now I would like to introduce our expert speaker today, Dr. Wade Watson. Dr. Watson is a professor of pediatrics at Dalhousie University, head of the Division of Allergy, IWK Health Center, and chair of the Specialty Committee, Clinical Immunology and Allergy, Royal College of Physicians and Surgeons of Canada. He is also a member of our Healthcare Advisory Board. Thank you, Dr. Watson, for joining us today. I'm going to pass it over to you in just a minute, and if you could also turn on your webcam.
And thank you very much for the invitation. So I've been asked to present on the differences between food intolerance and food allergy. I will preface before I start that I am a pediatric allergist, so some of what I say will have a pediatric bent, and I am not an expert on food intolerance. But we do have several learning objectives, so hopefully by the end of this session, you will be able to define an adverse reaction, food intolerance, and food allergy. You'll be able to explain the differences between an IgE and a non-IgE-mediated food allergy. You would hopefully be able to identify the more common food intolerances and food allergies and describe the symptoms, diagnosis, and management of both conditions. So I have some questions, not that I just want you to think about them, and you might want to just jot down your answer. So we have a 5-year-old child who developed bloating and abdominal pain after drinking cow's milk. So the most likely problem is it A, a food allergy, B, a food intolerance, or are you uncertain? So I'll give you a few moments to think about that. Question 2 is a 1-year-old male who is brought to the emergency department. He has generalized hives and a cough after eating peanut butter. So the most likely problem in this situation is A, a food allergy, B, a food intolerance, or C, you're uncertain. And the third question is a 6-month-old female started vomiting 2 hours after a bottle of cow's milk formula. She looks pale and lethargic. What is the most likely condition? Is that a food allergy, a food intolerance, or again, are you uncertain? With that, hopefully to stimulate your interest, we'll proceed on with the presentation. So just some definitions. So an adverse food reaction, that is a general term. It's any unfavorable response to the ingestion of a food. So if it involves the immune system, it's known as a food allergy. But if it does not involve the immune system, it's known as a food intolerance. So what I thought I would do is, what is the immune system? So just as a background, it's one of the body's defenses against harmful substances. The body produces either proteins called antibodies, or it produces cells which attack these substances. So the most appropriate is, attacking bacteria, parasites, and viruses that invade the body. But it also can produce to foods, and there are normal food immune responses and abnormal immune responses. And we'll come back to that a little bit later in the presentation. And the production of these proteins or cells is called an immunologic response. So when you hear that, you've got immunologic responses with a food allergy, this is what's happening in the body. So a food intolerance is a difficulty digesting or metabolizing a particular food or food component. And if you look at sort of food intolerances in the population, it can affect up to 20% of the population. But if you happen to be someone with irritable bowel syndrome, the food intolerances can be as high as 50 to 80%. Food allergy is an adverse reaction to a food due to an abnormal immunologic response following exposure. So it's usually ingestion. There are IgE-mediated responses where that's an antibody response, and there's non-IgE-mediated responses which involve cells in the body. So if we look at adverse reactions to foods as their overall term, we have food intolerances on the left, food allergy on the right. Food intolerance includes enzymatic issues, pharmacologic, toxic, and then there's an undefined. With food allergy, there's a non-IgE-mediated food allergy and IgE-mediated. So I'm going to spend a little bit of time right now on the whole issue of food intolerances. So the important thing to remember of a food intolerance, if you've got multi-system involvement in general for an IgE-mediated, but for food intolerance, predominantly gastrointestinal. So it may be nausea, vomiting, diarrhea, abdominal pain. So if you look at some of the enzymatic food intolerances, that means there's a lack of enzyme needed to break down the food. There's lactose intolerance, which is extremely common. Some people have problems digesting fructose, which is another sugar, and there are also general carbohydrate intolerances. And the symptoms that you get from these intolerances, you get bloating, you get gas, abdominal cramps, and you may get diarrhea after consumption. And the management for lactose, certainly there's a lactase enzyme prior to eating dairy products, which is certainly can be very helpful, or ingesting lactose-free dairy products. And I'll give you my own personal bent. I've spent the first 60 years thinking that I had the general Watson intestines, which meaning that we had trouble with bloating, gas, and diarrhea all the time until my son decided to go lactose-free. And then I realized that the symptoms that I'd been having for the previous 60 years was a lactose intolerance, and my symptoms are much better with lactase enzymes. There are some people who cannot digest fructose, so you avoid foods and beverages sweetened with fructose, crystalline fructose, or high fructose corn syrup. So that can be, high fructose corn syrup is found in a lot of processed foods. There are some individuals who seem to have more problems, especially with irritable bowel syndrome, where they seem to have problems with a number of carbohydrates. And so there is something called a FODMAP diet, where you avoid oligosaccharides, disaccharides, monosaccharides, and polyols. This is a very complex diet, and certainly it's only for the highly motivated. But I haven't spent too much time on that. But just to understand that the symptoms are the bloating, gas, diarrhea that I've mentioned above. There can be pharmacologic intolerances. So certainly some people seem to be more affected by caffeine. There is a chemical in tea and chocolate called theobromine that can also cause problems. Histamine is found in some wines and fish. Some people have trouble with alcohol, that they lack a particular enzyme, so they're unable to to break down alcohol. And then there's flavorings and preservatives, and sodium metabisulfites and MSG are the two most common. I only want to spend a little bit of time talking about sulfite sensitivity. So it's usually related to ingestion of sulfites. It affects patients with severe asthma. You get wheezing in response to dietary sulfites. So to allergic reactions, meaning an IgE-mediated response, is rare. And the management is to avoid foods high in sulfites. So grapes, dried fruits, wine, and processed meats are the most common. There are toxic responses, and again, food poisoning is the one that's most obvious. But in some seafoods, tuna and mackerel, if the tuna and mackerel are a little bit old, there seems to be a problem in that some of the breakdown in proteins can cause responses in some individuals, and this is known as scrumboid poisoning. So the diagnosis of a food intolerance, you really need to have a compatible history. And again, improvement with the trial of avoidance. So symptoms should improve with avoidance of the specific food or food component. And by definition, the diagnosis is usually confirmed by retrying that specific food and looking for return of symptoms. Having said that, there's a lot of patients, but if they avoid the particular foods, are very hesitant to retry them because the symptoms that they had were uncomfortable. So that's food intolerance. So we're going to move to food allergy now. So again, I show this body system for IgE-mediated food allergy. You can see that multi-system involvement is usually the norm with IgE-mediated allergies. You can get symptoms orally, you can get breathing issues, you can get stomach issues, gynecologic, uterine cramping as part of the allergic response. You can get symptoms in your upper respiratory tract infection, cardiovascular symptoms, and skin. So when you think about IgE-mediated reactions, think about multi-system involvement. And the key for these is that the symptoms tend to happen usually within 2 hours. And we used to call this immediate hypersensitivity. So symptoms within minutes or up to 2 hours. And obviously, food anaphylaxis is the one we all worry about the most. The definition of anaphylaxis has certainly been simplified over the last few years, and we consider it anaphylaxis if it meets one of the following criteria. So you need sudden onset, so minutes up to 2 hours. If it's symptoms involving two or more body systems, so you can have skin, respiratory, gastrointestinal, or stomach, or cardiovascular. And then you can have anaphylaxis with one symptom with known ingestion. So if you are peanut allergic and you ingest peanut, if there's a sudden drop in blood pressure or difficulty breathing, by definition, that's anaphylaxis. So it's important to reinforce the whole issue is hives do not always appear during anaphylactic reactions. The diagnosis of food allergy is IgE-mediated food allergy. You really have to have a history compatible with IgE food allergy. And what we do to confirm that history is epicutaneous or skin testing. And we can actually measure specific IgE levels on a blood test to confirm the history. I do want to talk about as the Canadian Society of Allergy and Clinical Immunology put out a position statement on food-specific IgG testing. And this certainly has been promoted as a way of diagnosing food allergy. But there is no research to support the use of to diagnose and predict future adverse reactions to foods. And as you remember previously, I said that sometimes immune responses to foods can be normal. And food-specific IgG, which is a specific type of immune protein, is a marker of exposure and tolerance to food. So measuring that food-specific IgG, a positive test is expected in normal or healthy individuals. So inappropriate use of this increases the likelihood of false diagnosis being made, which leads to unnecessary dietary restrictions and can have a significant impact on quality of life. So please, this is not something that is recommended at all. There's really does not help in the diagnosis of adverse reactions to foods or food allergy. So management of IgE-mediated food allergies, again, food avoidance. All individuals with an IgE-mediated food allergy should have access to an epinephrine autoinjector and carry it with them at all times. Oral immunotherapy is becoming increasingly a management option, but there's variable access across the country and even within provinces. And it's a shared decision making between families, patients, and their allergist. So now I just want to spend a little bit of time on non-IgE mediated food allergy. So this is part of the immune system where you get generation of cells that respond directly to a food protein, and they release chemicals that directly cause an inflammatory response. And it typically affects the gastrointestinal system only. So rather than multi-system with the IgE mediated, it's isolated stomach, intestines. So if we look at that body system, gastrointestinal symptoms are predominant with nausea, vomiting, diarrhea, and pain. And I know some of you are thinking, well, that's very similar to a food intolerance. But I want to reinforce that those symptoms are much more severe than a food intolerance. So non-IgE mediated food allergy conditions, there's a condition called food protein induced enterocolitis syndrome. This usually happens very early in life, shortly after the introduction of a new food protein. And typically there's an acute FPIES where you get repetitive vomiting, pale, and lethargy. So very tired, very sleepy, 1 to 3 hours after exposure. There's also a chronic form where you get vomiting, diarrhea, you get blood and mucus in the stools, and there's weight loss. So again, sudden and significant symptoms. There's also a condition called food protein-induced enteropathy, where you get protracted diarrhea, vomiting, and again, early in life, failure to thrive. So there's weight loss and problems with gaining weight. Another very common condition in predominantly breastfed babies is something called food protein-induced allergic proctocolitis. So FPIAP or AP for allergic proctocolitis. And that's flecks of blood and mucus in stools of predominantly breastfed babies. And for most of these, they're diagnosed in infancy by the symptoms that I mentioned and resolved with avoidance. So there's no test that we do except avoidance. And again, if you're the strict diagnosis means that you improve with avoidance and then the symptoms return with re-exposure. But I think most clinical allergists are fairly confident. So if the symptoms improve with avoidance, we'll have the patients continue to avoid, and at some point the foods are reintroduced. Eosinophilic esophagitis is a non-IgE-mediated food allergy condition. This is managed mostly by my gastrointestinal colleagues, and you get inflammation of the esophagus with trouble swallowing, sticking of foods, and vomiting. This can be diagnosed in childhood and in adults as well. The diagnosis of non-IgE mediated reactions is, as I said, the history compatible with the condition, resolution of symptoms with avoidance, and the potential for a food challenge with return of symptoms. The management of non-IgE mediated food reactions is avoidance of the inciting food. Through eosinophilic esophagitis, there are some improvements with dietary management. There are new pharmacologic treatments that are predominantly used other than dietary management. The use of biologics have also been introduced. And again, because of inflammation, in the GI world, they may have to dilate the esophagus. So I wanted to talk about celiac disease. That's separate. It's also known as gluten sensitive enteropathy. And it's a common immune-mediated inflammatory response, a disease of the small intestine. So it's not truly a food allergy, but it's a reaction to dietary gluten and related proteins in a genetically predisposed individuals. And these individuals present with diarrhea, gas, weight loss. They may be anemic. So just from an issue about food intolerance versus a non-IgE food allergy, because again, as I said, both involve the digestive system. And for food intolerance, the amount of food ingested is equal to the severity of symptoms. So in some individuals, small amount of foods may not cause any symptoms, but as you increase the amount of food ingested, the symptoms also increase. And there's similar symptoms with each exposure. For non-IgE food allergy, small amounts of food can cause severe reactions. And in general, even though the digestive systems involved in both reactions are more severe than that with food intolerances, and most start in infancy and childhood. So summary is that for food intolerance, really can develop any time. As I said, digestive system, bloating, flatulence, diarrhea, amount of food ingested equals severity of symptoms. Similar symptoms with each exposure, and their symptoms are less severe than food allergy. With food allergy, most develop in infancy and childhood. IgE mediated, so you develop immune proteins, get multi-system involvement. There's a risk of anaphylaxis, and management is avoidance. As I mentioned, oral immunotherapy is an option depending on the food, age, and geographic location. With non-IgE mediated, again, involves the digestive system, the avoidance, and there's a possibility of outgrowing those non-IgE mediated reactions in most situations. So I realize that was a quick summary, but now we have lots of time for questions. But just returning to our questions that we talked about. So the 5-year-old who developed bloating and abdominal pain after drinking cow's milk, the most likely problem is a food intolerance. This sounds typical for a lactose intolerance. A 1-year-old with generalized hives and cough after eating peanut butter, that is most likely an IgE-mediated food allergy. And the 6-month-old female with vomiting 2 hours after a bottle of cow's milk formula, she has pale and lethargy. This is most consistent with a non-IgE food allergy or FPIES. So with regards to our objectives, I hope I've defined adverse reactions, food intolerance, and food allergy for you, that you now can be explain the differences between an IgE and non-IgE mediated food allergy. I help you identify more common food intolerances and the food allergies. And we talked and described the symptoms, diagnosis, and management of both conditions.
Thank you so much for going through that presentation and providing some context for the audience. We did have a lot of questions that did come in, so I'll just get right on into it. So do food intolerance and food sensitivity mean the same thing? That's more, I think, terminology and how people talk about it.
Certainly a lot of my colleagues use the term food sensitivity, but I think they're really talking about a food intolerance. When I looked up the Canada Food Inspections Agency has sensitivities if you react more to chemicals in the food. So a sulfite intolerance, they call it a sulfite sensitivity. So I think in that sort of situation, it is more related if there's a chemical in the food that reacting to, but I think they're both food intolerances.
Okay. And then someone just asked, can someone have both food intolerance and food allergy?
Oh, absolutely. Certainly, I have patients who have had cow milk allergy where they have had hives and typical symptoms. And then when we do challenges later on, when we're looking to see if they've outgrown the allergy, a lot of them may develop bloating, gas, and diarrhea, which is a lactose intolerance, which probably was there before, but the IgE-mediated reactions were more prevalent. But yeah, I think people can have both. If you think about food allergy in adults, it's probably what 3%, 5 to 8 in children. Food intolerances are 20%. So the overlap is probably quite common.
Okay. Um, If you are intolerant to something, can you do anything to become more tolerant to it? And can food intolerance be reduced over time with medication?
The only one that I can really comment on for that is a lactose intolerance. And certainly, if someone has a lactose intolerance, there is the lactase enzyme that you can take before eating lactose-containing foods that help to uh, reduce symptoms because it helps to break down the sugar that's in the lactose sugar so that you're able to tolerate it. I mean, I think intolerances probably are change over time, but I don't think there's anything that you can do that's going to make a difference. I mean, certainly if you have a fructose intolerance, you try to avoid the sugars, the fructose sugar. Um, I mean, other than avoidance, I know of no other than lactase enzymes, I know of no other way they're going to treat that.
Okay. Can food intolerance develop into food allergy?
Well, I think the other thing is, can a food that causes intolerance also cause a food allergy? The answer is yes, but I don't think one will lead to the other. I mean, if you have
Hmm.
trouble breaking down sugars or whatever in a particular food thing, that doesn't necessarily mean your body's going to develop an immune reaction. But so I think that there are certain foods that can cause both. So for example, milk can cause a
Hmm.
lactose intolerance, but it can cause a milk allergy. But one does not increase your risk for the other.
Okay. We had a question come in about peanut. Someone asked if you can be intolerant to peanuts, where the symptoms are no rash, no issues with breathing, but will vomit within an hour after eating. Is that intolerance or is that an allergy?
Well, I always worry in regards to peanut, especially if you have vomiting. You know, acute FPIES is 1 to 4 hours after exposure to a food where you can get vomiting. Now, the vomiting tends to be repetitive. An intolerance is more so maybe, abdominal pain, diarrhea, that sort of thing. So when it comes to peanut, I would worry a little bit more about acute FPIES than I would be for a peanut intolerance. I mean, you can be intolerant to any food, but I would certainly rule that out before saying that this is just a food intolerance.
Okay. And related to FPI, so somebody just asked how common FPIES is in adults. I'm not sure if you know
Um,
that.
so certainly the big thing for FPIES in adults, and again, this anybody over the age of 19 makes me uncomfortable as a patient,
Mhm.
but FPIES is very common with regards to shellfish. It's certainly in Atlantic Canada, we have a number of, I mean, my colleagues have a number of adult patients who develop profound vomiting after ingestion of scallops, and it sounds like acute FPIES. And so the issue is that they are fine with avoidance. With regards to what happens over time, nobody ever seems to want to eat the scallops again. So it tends to be something that is potentially long term. I've had patients who've had enough pies in childhood to say lobster or scallops, and I've challenged them at 17 and they still have it.
Mhm.
I've had one colleague who developed FPI symptoms after eating quail eggs, but I don't know if that was food poisoning, but again,
Mhm.
profound vomiting about 4 hours later.
So for those, she had also asked if it's in children and those who grow out by 1 year or 3 years, and if they don't grow out of it, is there an age that people might grow out of FPIES
Well,
after
certainly
3 years?
the liquid, if you react to sort of things like soy milk or cow's milk, those sorts of things,
Mhm.
certainly, I've that 18 months to 2 years seems to be fairly common. If you react to a solid food, so over time, I've had patients who've had, say, acute pies with oats, barley, and rice. And, it took them 6 to 8 years before they outgrow it. With regards to
Mhm.
the shellfish, as I said, many of them don't want to try it again. And those who have tried it, at my experience, I haven't had anyone outgrow shellfish F pies yet. But again, I haven't
Mhm.
challenged many because nobody wants to eat it again.
Okay. And then related to peanut, somebody wrote in saying that they had multiple food allergies. They outgrew most of them except for peanut. They're now an adult. So wondering, do you typically grow out of peanut allergy or no, is that more of a lifelong allergy?
Well, certainly, you can never say never. I mean, the statistics were, with regards to peanut, that it was probably, less than 10 to 15% that would actually outgrow. And then the other thing is that the longer a food allergy persists, the less likely you are to outgrow it. Peanuts a very, I wouldn't call it special, but it's a very specific I mean, it's very highly repeated structures, and that
Hmm.
it really does cause the body's immune system to make lots of IgE. So, again, I have not had, I've had a few patients outgrow. I've been seeing patients for almost 40 years. But the issue is even for patients who've had reactions very early in life, I challenged one 13 years later, and then unfortunately, they've had really severe reaction. So, yes, it's possible, but it's much less likely than the other foods.
Okay. Since we were just talking about seafood, somebody just wrote in talking about shrimp. So that their son ate shrimp with no issues, but after turning 30, started feeling like his lips and tongue were swelling and he had a bit of a hard time breathing. Is that developing an allergy to shrimp?
Well, it sounds suspicious, so I would
Mhm.
recommend that they see somebody that actually can do a formal assessment and testing. So, can a food allergy develop any time? Yes. But the issue is that that would be a person that would require testing, and if the testing was negative, they would I would challenge them to determine what type of symptoms they're having.
Okay. What is a hereditary pattern? If the parent has a food allergy or food intolerance, will their child?
So with regards to, I mean, you don't inherit specific food allergies, you inherit the ability to make allergic protein. So the statistics that I've always quoted and is that, the basic risk for any type of allergy is about 10 to 15%. If one parent has allergies, the risk doubles to about 30%. If both parents have allergies, that risk is close to 45%. But specifically with regards to if you have a peanut allergy, do you um, genetically pass that on
Mhm.
to your child? The answer is no. There's no evidence that I can find. With regards to food intolerances, I do think, especially lactose intolerance, there's usually a very there's other family members who have that intolerance, and so certainly it is possible to pass on that. With regards to fructose and those sorts of things, I don't have any numbers, but I do know with lactose over the years, I've had a number of it, say mom or dad has a lactose
Mhm.
intolerance, their brothers and sisters, father, and then the child presents with symptoms that are quite compatible.
Okay. Just a clarification question. We had somebody ask, talking about how we've talked about intolerance doesn't turn into an allergy. Can an allergy reduce to an intolerance? So I know you had touched on that
Um,
before, but if you can just clarify.
Well, from my point of view, I mean, they're different mechanisms. If you lack an enzyme to break down a sugar, that doesn't necessarily mean that and if you make allergic protein, again, I'm going to pick milk because milk would be the
Mhm.
one that's very common.
Mhm.
So, certainly is that if you could have a lactose intolerance and a cow milk allergy, but the initial presentation may be the symptoms of the allergy with hives, breathing problems, vomiting, that sort of thing. So the avoidance may help improve the prognosis, and they outgrow the allergy component. but they still lack the enzyme to break down the sugar. So I don't know if it's turning into, it's just that one resolves and the other one is still there.
Okay, that's helpful. Somebody did ask if there's a difference between having egg allergy and egg intolerance.
Again, egg allergy would be multi-system involvement, certainly so hives, breathing problems, vomiting, and that sort of thing. I mean, certainly there are a number of people who are intolerant of eggs and what they would have, or aversion to egg. I'm laughing because I have I have a friend who has 6 boxes of Cheerios on his cabinet because he hates eggs and the Cheerios go on sale every 6 weeks, so he uses 6 boxes in 6 weeks. But certainly it, and then egg can also cause an FPI. So early
Mm-hmm,
in life with significant vomiting, lethargy, the diarrhea, that sort of thing. So it really depends upon the severity of symptoms when they start, and
mm-hmm,
uh, what happens with avoidance.
mm-hmm.
So I don't know if I've answered it, but you can have an egg, and I think you can have an egg intolerance. You can have an egg allergy. You can also have an FPIES to egg. So again, it's the type of symptoms you're having, the severity, what systems are involved, and how severe they are will help you sort that through.
Thank you. I know it can be really complex, and so that ties in nicely to the next question, which are what are the best strategies for identifying a food intolerance when you aren't exactly sure what's causing symptoms?
So again, it depends on the severity of symptoms. So I mean, when I see a child or an adolescent where they're having, gastrointestinal symptoms, and they haven't been able to identify, any specific foods, I will have them complete a food and symptom diary. And so typically, you don't want to do it over a long period of time, but long enough so that, if there are identifiable triggers that they should be able to help do by keeping the diary. And then again, what I mean by the diary, so what foods are you eating? And then so you've got a day, so breakfast, snack or lunch, snack, dinner, and what symptoms are you having, and trying to sort of correlate those symptoms with the foods. And certainly if there is a potential, it can identify some potential triggers, then by definition, avoiding those triggers should resolve those symptoms. And then so you want to have a resolution of symptoms. And again, depending on the severity of symptoms, by definition, you want to reintroduce the food to see if the symptoms return, because sometimes the symptoms will get better and you put the food back in the diet and all of a sudden there's still no symptoms. So maybe there was something else that was going on. And so in order for you really to identify a food for an intolerance, it's a reintroduction with return of symptoms.
Okay. And then who can diagnose food intolerances? Is it worth to have them officially diagnosed? And again, maybe you can also again talk about the lab testing that's widely promoted throughout Canada on this.
Well, I mean, again, food intolerance is, I'll give you the more common ones. As I said, there's a lot of people that are, or there's been a lot of promotion of specific IgG testing for food intolerances, but that is not helpful because it really is just measuring specific IgG to foods, which is a normal response. And I think the thing is it depends on the degree of symptoms that you're having. So, certainly working with your family doctor if they don't have time, and depending on the severity of symptoms, uh, are you referred to a subspecialist or a dietitian? Those individuals can also help. I mean, I have promoted the use of food diaries over the years in order to help individuals identify potential triggers. And if they can't identify anything, then the chances are there's probably not an association. And if they do, certainly the trial of avoidance can be helpful. I've diagnosed more lactose intolerances in the last 10 or 15 years than previous to that. And again, it's because the symptoms are pretty common, and the more milk that somebody drinks, the more symptoms that they're having. And then you ask about family history, and you find that there's other individuals that are similar, and their symptoms improve with the use of the lactase
Mhm.
enzymes.
Okay, that's great. What's the difference between food intolerance and pollen food allergy syndrome or oral allergy syndrome?
So that's a very good question. So pollen food allergy syndrome, which is the most recent name for it, is the individual is allergic to pollen. So this, I picked the specific one. There's birch pollen, and
Hmm.
because they're allergic to birch pollen, they react to different proteins in the birch pollen, and some of those proteins are also plant storage proteins that are found in fresh fruits and fresh vegetables. So the most common one would be if you're birch pollen allergic, and then you get oral itch and maybe itch in the back of your throat after eating a raw apple or carrot. And but those are the only symptoms that you have. You don't have any other systemic symptoms. And the cooked vegetable or cooked fruit. So if you have a cooked apple, it doesn't trigger the symptoms. And that's because the protein that you're reacting to is very what we call labile. So, as soon as it hits the stomach, the acid breaks down that protein, so you don't get any systemic symptoms. Your risk of having anaphylaxis if you have pollen food allergy syndrome is less than 1%. Now, there are people with a primary food allergy and do not have a pollen allergy, and their risk is much higher for having anaphylaxis. So you must, in order for you to have pollen food allergy syndrome, you must have the pollen allergy.
Okay. Um, we had another question about FPIEs. Lots of questions on FPIEs. Do FPIE symptoms tend to get less acute with age? So younger
Well,
means more
that's
severe, older less severe.
well, that's a good question. Certainly my experience is younger, they don't tolerate the symptoms as well as they do when they're older. So for example, a 6-month-old with recurrent vomiting with FPI, say to cow's milk, I mean, certainly their tolerance and their risk for dehydration is much greater than if they're 2 or 3 years old. But certainly, so whether or not severity of symptoms is different, or more importantly, whether or not their ability to tolerate the vomiting is better. So certainly, I'm less concerned about a 16-year-old that I'm doing an FPIES challenge than if I'm doing an FPIES challenge to a 1-year-old.
Mm-hmm. Okay. Are food intolerances lifelong? Do you know?
It's a good question. Certainly, I mean, I think depending, I mean, lactose intolerance certainly seems to be something that is seems to be around for life. With regards to these other ones, I honestly, I don't see them that much, so I'm not certain. But I think, certainly if somebody has, irritable bowel syndrome and reacting some of these carbohydrates, they may change over time, but I'm really not certain.
Okay.
Not my area
Um,
of expertise.
no, that's fair. And then just back on pollen food allergy syndrome, somebody asked, what are the most common foods involved in PFAS?
Well, there's a huge list, and I will
Hmm.
direct you to the Food Allergy Canada website, which has a lovely
Yes.
downloadable table. But certain for birch pollen, if you're birch pollen allergic, the most common is apple, carrot, hazelnut can be
Hmm.
associated. And interestingly, birch pollen and peanut can also. There are individuals who get oral itch with peanut, and one of the components of the peanut protein will cross-react with birch pollen. And again, trying to sort that through with an individual. So, because I mean, if you have a peanut allergy, that's a carry significant risk. But if you have pollen food allergy syndrome, ragweed, I think with some melons seems to be something I
Hmm.
remember. But honestly, it's on a list, so it's not in my
Yes.
head because it's on a list.
No, no problem. I was going to say as well that we do, as you mentioned, we do have this beautiful one pager that talks through the most common triggers, the most common foods by season, by pollen. So we'll share that information at the end as well. We had a question about migraines. Are migraines considered to be a manifestation of food intolerance?
Well, there are certainly food triggers for migraines. And again, I guess it would be a debate. And certainly when I looked at the literature prior to giving this presentation, there are things called tyramines and nitrates that are found in aged cheeses, wine, and nuts, and some of these prepared meats like salami and pepperoni that for certain individuals can be a trigger for migraines. But migraines, too much sleep, too little sleep, stress, all of
Mm-hmm.
those sorts of things can
Mm-hmm.
also be triggers. So I think there are food triggers for migraine headaches. So by definition, that would probably could be considered a manifestation of a food intolerance. But again, you're talking about a condition that has many triggers as well.
Okay. This one I'm not sure how much you'll be able to advise on, but
I will do
how do,
my best.
yes. How do you support people with unexplained reactions? Example, ingestion of milk protein causing extreme mood swings and GI discomfort.
So what I usually tell families in that sort of situation, I mean,
Hmm.
if those are the symptoms that you're having, and the symptoms improve with avoidance, and they return if you have the milk again, then you avoid the milk.
Hmm.
Uh, and again, I've become very practical as I've gotten older. I mean,
Hmm.
in young children, even, what you really need milk for is calcium and vitamin D, which is found in many other foods. And certainly, any sort of milk alternatives are usually fortified with vitamin D and calcium. So if food consistently causes those symptoms, um, then you avoid the food as long as it's not affecting you nutritionally.
Okay.
Meaning, if are you getting enough calcium and vitamin D?
Hmm. Okay. We have a few questions on EOE. Um,
Yes.
so can
Again,
EOE
not
happen
my
in,
area of expertise.
I think this one I think you'll be able to answer with that. Can EOE
Okay.
happen in kids and adults?
Yes, absolutely. I've diagnosed eosinophilic esophagitis, and well, in retrospective, I had a 3 or 4 year old who had really chronic problems with ingestion of foods and really was very irritated. We treated for what we call reflux. Its symptoms didn't improve. And, we've referred on to our gastrointestinal colleagues when they actually looked. There was inflammation in the esophagus, and it was proven to be eosinophilic esophagitis. So it can occur at any age.
Okay. Um, and then somebody had asked if elevated eosinophils in the blood work are indicative of EOE.
No, it's it's the it's diagnosed by actually looking in the esophagus, and you see inflammation. There's other signs that they use, but you biopsy the area, and there are specific criteria for the number of eosinophils when they look under the microscope. So, but elevated eosinophils in the bloodstream are, if you have eczema, you have
Hmm.
elevated eosinophils in your bloodstream. So
Okay.
it's a very non-specific thing that's there.
Okay. Can you be intolerant to many foods, just like how somebody can have multiple food allergy? Um, can you have multiple food intolerances?
Well, I think that's a whole issue with regards to patients with irritable bowel syndrome. The whole issue in there. And again, it's not my area of expertise, but a lot of individuals with irritable bowel syndrome will have numerous foods, and certainly this carbohydrate. Some people have trouble
Mm-hmm.
with carbohydrates in general, and that's where the consideration of this FODMAP diet
Mm-hmm.
is, which is avoiding the foods that are high in the number of sugars that I mentioned. The problem with that diet, it's very onerous and it's very difficult.
Mm-hmm.
And so, certainly it is something that would be a trial of avoidance and looking for improvement of symptoms. And again, recurrence of symptoms with introduction of these foods back into the diet. Because not everybody will react to all of the different sugars. So you avoid them and then you start putting them back in one at a time. Again, working with a dietitian or our GI colleagues seems to be far more spend a far more time on that. I certainly don't see patients with that condition.
And what does FODMAP stand for again?
Well, I have to. It's the.
Yeah.
Well, it's the avoidance of fructose and all these other sugars. It's back in my
Okay.
presentation there
Yes.
for the different carbohydrates. So
Okay.
I would suggest look up FODMAP diet, and it has a list of all of the things that
Okay.
are there.
And then somebody had asked, how long should you keep a food diary for? Is it a week, 2 weeks, 6 months? Like how long?
Well, it depends. Oh, no, no. Most people have a fairly consistent diet, so if you eat, I tend to eat the same foods on a
Mm-hmm.
daily basis. I would think if you were looking, even a maximum of 2 weeks, that by 2 weeks you would certainly my diet's so limited. I think for me, it would probably be 1 week. But, if you're eating the same foods over and over, you don't need, and your symptoms are more regular. Now, if you're having very intermittent symptoms, so if you're having symptoms once every 2 weeks, then, certainly keeping a daily food diary makes no sense. But if you start having symptoms, doing a food recall may be helpful, but it depends on how frequent the symptoms are and how varied your diet is. But certainly a week to 2 weeks should give you more than enough information.
And then that's the same if you have a food intolerance versus food allergy, right? The length of time you'd keep your food diary. I don't think that
Well,
matters.
food allergy, no, I don't, but again, if you have an IgE-mediated food allergy, it doesn't take you very long
Mm-hmm.
uh, to look at that association for FPIEs, that sort of thing. Again,
Mm-hmm.
most people that I see with an IgE or even non-IgE mediated allergy come with the diagnosis, and I'm there just to sort of reinforce the diagnosis with them. When it comes to less the less specific the symptoms are, or they're more chronic, and if they're vague, and if they're looking
Mm-hmm.
for association with foods, that's when I would do the food diary.
Okay. That's great. I think we had a ton of questions come in. I'll just do a quick check. I don't think we have any further, but this has been super, super helpful and really helped to our audience to figure out what's food allergy, what's intolerance. I know it's a very broad spectrum of things, but I so appreciate your expertise. And then with that, I'm gonna just do a few more slides so we can turn off our cameras, and I will share my screen. And as we mentioned before, we have a lot of the resources up on our site afterwards that you guys can go to as well. So what's next? We will be sending a post-session survey to the audience immediately right after. This survey really does help us understand your feedback, not only for this session, but also to give us more thoughts for future webinars and what you might be interested in learning about. Back to school is completely fully underway. We are, if you haven't already, go to our back to school campaign section. Take advantage of the host of resources. You can go to foodallergycanada.ca/back to school. There you will find videos and handouts like those that you see on the screen and more. And as I mentioned, our campaign ends today, but we will still be keeping the content up on our site for the school year, so you can refer back to the resources all year long. You can also check out Allergy Check. This is an app which is intended to help people understand whether specific symptoms may be caused by a food allergy and whether further advice from an allergist is recommended. So that might help some people when there is a lot of confusion of figuring out what you may have. The investigators at UBC and the digital lab at BC Children's Hospital collaborated to create Allergy Check with support from Food Allergy Canada and the Canadian Society of Allergy and Clinical Immunology. On the next slide here, you'll see that we've covered a lot of information today. Dr. Watson did help provide a lot of clarity. We do a deeper dive on a few of the topics covered, including EOE. We have a dedicated section on our website which includes information on diagnosis, treatment, and management. And we also have a host of resources, including 2 webinars with gastroenterologists and a dietitian, one focused on EOE in children and another on EOE in adults. So I recommend you check them out. We also have recorded webinars on FPIES, cow's milk protein allergy in babies, MPA, and pollen food allergy syndrome. You can view these webinars and more at foodallergycanada.ca/webinars. We also do have another webinar coming up on October 23rd. It's on the future outlook of food allergy treatments. That session will cover treatments like allergen immunotherapy, biologics, and newer therapeutic approaches. So don't miss out on that session. It's going to be with Dr. Cecilia Barron. So you can register now at foodallergycanada.ca/events. And I also want to thank our sponsors for their support. We have EpiPen, the Peanut Bureau of Canada, and Chapman's, who have generously supported the Back to School campaign and this webinar. And I would like to also thank everyone for their participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share with others who may benefit from this content. This now concludes the webinar.